So without further ado, patient-centered care, workplace safety, creating a culture of care and respect. Paul Perryman, MSN, MS, RN, NEBC, and Catherine Capp, MSN, RN, NEBC. Well, we've got a lengthy description there, but what I'm going to do is go to our abbreviated version here. But first, I want to say welcome, Paul, welcome, Catherine. We are so glad to have you both here today. Really appreciate your being here. Paul, we know that in addition to those different degrees that I just mentioned, provided active support in opening the Youth Behavioral Health Center in Butner, North Carolina. And of course, we're all here in North Carolina very excited and proud about that. We had that you worked on the development of the Behavioral Response System and Oversight Committee for UNC Hospitals on the Chapel Hill campus. Named one of the North Carolina Great 100 Nurses, excellent, and named Nurse Manager of the Year for UNC Hospitals in 2019. So those are things you've got to be very proud of. Catherine, glad to have you here as well. And in addition to the degrees mentioned there, lead and achieved organizational goal efforts in the fiscal year 24 to train workplace safety champions on every inpatient unit at UNC Medical Center. And since Hillsborough opened, I can't believe it's 9 years. Is it really 9 years ago that Hillsborough opened?
More than 9 years ago now.
Wow. Has led Carolina Care efforts. Hillsborough campus is a 4-time winner of the Press Ganey Guardian of Excellence Award, awarded to hospitals in the top 5th percentile for patient experience in the country. And during Catherine's time as nurse manager of the inpatient surgery unit, the Hillsborough campus earned total hip and knee replacement certification through the Joint Commission. So great accolades for you as well. There's that sample poll everywhere question. WPV is the abbreviation for workplace violence. That's a true false. While you're thinking about that, I'll go ahead and put up our disclosures. So there they are. You've seen them. And then we'll give folks just a few more seconds. I should have mentioned all these poll everywhere questions. They're all anonymous. We're not going to grade you on these. So put in your best guess as to what the answer is. They're saying WPV stands for workplace violence. True, 100%. How are they doing?
Doing really well.
Doing well. All right,
Very
they got
impressive.
it. All right. Well, with that, I'm going to turn this over to Paul. I think you're going to get started on this. So let me give you the controls. Workplace safety, creating a culture of care and respect.
All right, great. Thanks again for having us today. I just wanted to also state that, like, currently I am the director for inpatient medicine at UNC Medical Center, which does include for oncology and the bone marrow transplant unit. Additionally, I do have a history of being the co-chair of the Workplace Safety Program Council, which I handed off to Catherine over here not too long ago. All right, so today we're going to talk primarily about workplace violence, but it's a really interesting topic in how it interfaces with workplace safety. And the reason we said creating a culture of care and respect is because there's really two sides of the coin when we're talking about workplace violence. One of those sides is the teammate perspective and what they're experiencing, whether it's at the bedside, in an outpatient setting, or at home even. And then there's also the patient side. What's happening with that patient? What's leading to this, leading up to this event that's, creating this workplace violence? So we kind of want to walk through a few pieces of that today with you. So we're going to start by going through some of our objectives for today. So I'm going to go ahead and populate all of these. All right, so we're going to start off today. I'll start us off by talking about the scope of workplace violence in the United States.
And then I will define workplace violence and its domains.
And I will follow that up with talking about regulatory requirements to address workplace violence in healthcare settings.
And then we will discuss strategies to prevent workplace violence that are specific to healthcare settings.
And then we'll kind of both tag team the review in institutional structures that we've helped put in place here at UNC to address workplace violence prevention and response. And some of these things we'll be covering like individual, but we'll also kind of supplement one another as we present. So I'm going to start us off by talking about the state of violence in healthcare. So we've got a lot of kind of high-level statistics here, starting off with from the years 2021 to 2022, it's reported that there were 57,610 reported incidents of workplace violence, leading to days away from work or leaving an organization altogether. So it's really important to make that distinction that this isn't just workplace violence. It's very specific scope in that it actually led to people missing out from work or leaving an organization. And this is for all occupations across the United States. Of that number that I reported, 69% of these cases involve healthcare workers. 25% of nurses report being assaulted in the acute care setting in one study. And then in another study, 13% of RN missed days of work were related to workplace violence. So definitely an impact in healthcare, and more specifically, we're talking here about nurses, but it's not just nurses who are experiencing this workplace violence. Also, the Bureau of Labor Statistics has done a lot of work trying to capture non-fatal workplace violence to healthcare workers, and from the years 2011 to 2018, they showed a 62% increase over time of the incidence of non-fatal workplace violence. And then from 2018 to 2022, it's really sustained, not seeing that continued growth, but it has sustained over time. And it's something that's always important to realize and recognize when you're talking about these statistics is that there is evidence that workplace violence is grossly underreported. So one study that we cite here estimates that 12% of events are reported, and Catherine's going to talk a little bit more about what we think is being reported here at UNC later on in our conversation. So that's really looking at things from a high level, but anybody who's worked with workplace violence knows that this is very personal. This is one quote that we found in a resource from a RN that says, "I've been bitten, kicked, punched, pushed, pinched, shoved, scratched, and spat upon. I've been bullied and called very ugly names. I've had my life, the life of my unborn child, and of my family members threatened, requiring security to escort to my car." And while we hate that this happens to anybody, the reason we picked this quote is because it really covers the continuum of violence that healthcare workers can be exposed to in their care setting. And then, of course, bringing it back to the oncology setting, literature most often focuses on workplace violence in the emergency setting and in mental health settings, but oncology settings also have high risk for workplace violence. So really all clinical settings can benefit from talking about workplace violence and how to address workplace violence in their settings. Another thing that was noted is that workplace violence in oncology setting has worsened during the pandemic. And for any of you, those of you who have had to kind of enforce new visitor restrictions for infection prevention reason during the pandemic, or delayed treatments due to supply chain issues, resource scarcity, increased fears or fears that are exacerbated during the pandemic, you know what this is referring to. So one of the things we'll be looking at, over the next few years is, as these restrictions start to be removed, will we see a decrease in workplace violence in the oncology setting? So that's kind of what it looks like from a global perspective, and Catherine's going to walk through a little bit about workplace violence definitions.
All right, thank you, Paul. So like Paul mentioned, I am the current chair of the Workplace Violence program counsel here at the medical center, and I want to give the disclaimer that this is the working definition of workplace violence that we use here at UNC hospitals, but we do believe that it is supported by the literature, and it can be applicable to other healthcare settings as well. So the definition that we use is any violent action that may cause physical or emotional harm directed at persons at work or because of their work. So it can be vertical or lateral or horizontal, which looks like it could be peer-to-peer, which would be horizontal, or it could be lateral. So it could be a staff member and someone in their line of leadership, or it could be a patient to one of their caregivers. All right, and it's very important to note that to be considered workplace violence, an action does not have to be done on purpose. A person does not have to feel harmed, and an underlying diagnosis is not considered. And we really stress this with staff because it's very important that we quantify all workplace violence events that occur. We don't want people reporting only when they feel harmed, because there are many instances in healthcare that we know where people may excuse behavior because they are used to tolerating it, or they excuse it because they believe it to be part of their disease process. We want all events to be reported and quantified. So we know that one event can affect multiple staff members, either through direct contact. Witnesses can be impacted by workplace violence, and or it could be because the event created a hostile environment. So we know that one event or one person that is disruptive on a unit, a clinic, or a team can really cause great harm or widespread harm and be very disruptive to teams and dynamics in the workplace.
And one of the reasons this is important, Catherine, is because when we're trying to quantify what staff are facing in the front lines, this is often where we see a gap in reporting. So let's say 4 people are impacted by workplace violence in one event, maybe only one person actually reports it. So you automatically have an underreporting in that circumstance.
Yes, that's very true. All right, and then we also identify the 5 domains of workplace violence. Workplace violence can occur on a long continuum, and we also want to give people language or terms that they can use to really identify behaviors that are happening or events that are happening, so that they're able to, like I said, identify and then report and call workplace violence what it is. So the 5 domains are threats, physical violence, verbal or written violence, harassment, bullying, intimidation, hostility, and other disruptive behaviors.
Okay, thank you for that, Catherine. I'm going to transition us now, and we're going to talk a little bit about some of the regulatory requirements that have come out over the past few years related to workplace violence. Namely, in the hospital setting, at UNC hospitals, we really apply this both to our outpatient setting and inpatient setting as much as we can. So here's our first question here. How often are hospitals required to assess the organization's or an organization's workplace violence program?
All right, and thanks. I see somebody already got that first answer in. So we appreciate that. Thank you to others for jumping in and going ahead and either sharing the answer because you know it or taking your best guess, and either one is fine. How are they doing?
They're doing pretty well so far.
Good.
Trending right. All right,
So
great.
once a year.
Once a year.
Okay.
Yep, annually. Strong work. All right, so here so these are a very high level kind of summary of the Joint Commission standards that we kind of wanted to highlight. So environment of care, which really looks at like life safety and employee safety and patient safety. requires, that element of performance requires an annual assessment and risk mitigation action plan for an organization. What does that mean? It can mean whatever the organization says it means in their policy, but generally the idea is you're assessing what is the risk of violence happening within your organization, and what is your plan to address the safety risk that you've identified in your assessment. Also, you need to have a system for monitoring the violence, which really requires you to have a system for reporting it and how you're going to investigate and follow up on those workplace violence events. And so those kind of feed into one another because you need to have that system in order to do your assessment. Also, human resources. Hospitals are required to have a program to provide training both on hire and annually, and whenever there's a change in your workplace violence prevention program. Again, this can look very different from organization to organization based on what they've established as their priorities within their policies. And then lastly is leadership. And I think this is a really important standard that came out of Joint Commission and has been very helpful to our Workplace Safety Program Council here at UNC Hospitals. The leadership at the standard says you need to have a prevention program that's led by a designated individual and have multidisciplinary members. And so that's really empowered our group to have a nurse leader and a clinician leader operating as the co-chairs for our workplace safety program, and we've had that in place. But also the program needs to include a prevention program, policies, and processes for reviewing events, analyzing trends, and providing follow-up. And it's not really clearly stated here, but really you're required to report up through your governing board for the hospital. And that's where this standard really gives a lot of power and influence to these workplace safety program councils to make sure they have the tools to capture the data to represent what is the actual risk for violence to frontline teammates. All right, so now I'm going to hand it off to Catherine again. She's going to talk about some of our systems for workplace violence prevention.
All right, thank you, Paul. So we're going to walk through some different strategies around de-escalation that are very important to not only handle workplace violence events, but prevent them as well. And we're going to start with an inpatient scenario that we'll use throughout this part of the presentation. So the scenario is you walk into a patient's room to get a point of care blood glucose before breakfast tray arrives. The patient, Mr. Smith, yells at you to get out of my room. I am not getting pricked by another needle. You know his blood glucose levels are needed before he gets insulin. What do you do? So based on this scenario, we'll give you a minute to decide what action you are going to take as the caregiver.
And I know that text is a little bit small, so just in case you're having trouble viewing all of that, A is tell the patient that he has a duty to himself to get his blood sugar taken when it is scheduled. B, give the patient a choice of getting his blood sugar now or at the time they think would work within 30 minutes of before breakfast arrives. C, tell the patient that you know what is best and buckle up for the ride to health. Something about that language doesn't sound right. Or D, given the patient's resistance for blood sugar, give in to the patient's resistance for blood sugar and hope for the best. I don't know, something about that language doesn't sound right either. Howard, it looks like everyone's really coalescing around B. How are they doing?
Yes, they are on the right track, and we will talk more about this. So B is the correct answer of giving the patient the choice, letting them direct their care, and choose their kind of goals and timing for the day, and being willing to partner with them on that. All right, so we are going to talk through some de-escalation strategies. So the first one is, and you would use these strategies in all interactions with team members, patients, and visitors. And you want to, because you don't always know what's going on with somebody. So all people that you encounter, especially in healthcare, are dealing with pretty stressful situations, and we don't know another person's level of anxiety or their lack of coping skills, perhaps, and what illnesses or comorbidities that they are dealing with. So these are very important to keep in mind when you are dealing with others. So you would first want to respect personal space. So this is personal boundaries. Even if you are a direct caregiver for a patient, you always want to approach somebody slowly and ask permission to get close to them or touch them if that is needed for providing care. Next, you want to actively listen. You don't want to dismiss concerns, talk over somebody. Patients and visitors already feel loss of control when they are in a healthcare setting, so we want to make sure that we are respecting them and actively listening. Maintaining distance, so this would be when you're entering into any situation with another person, you want to stay at a at least an arm's length distance away from them while you assess the other person's kind of aggression level. You never want to get close enough if somebody is agitated that they could throw or reach out and hit you. You want to be aware of your surroundings. So if you're alone with a patient in a room, you want to make sure that you're closer to the door, you're not trapped in a corner. Using the buddy system if you need to, if you feel unsafe around someone else. And then lastly would be use non-threatening verbal communication and narrating your care. So what the term narrating care means is that you would always explain why you are doing something, preferably before you do it. So you don't just walk in a room without speaking and go about doing things to another person. You want to take the time to make sure that you're asking permission and that they understand what and why you're doing something. I think we've touched on a lot of these, but it's very important that you don't move too quickly. Touch unless necessary, and use a defensive tone of voice, language, or nonverbal positions. This last one I see a lot in healthcare, especially in my experience over the years, and I know Paul has too, that people can be very not very self-aware of their behavior, and it's not easy for them to regulate themselves when they are in stressful situations. So as another person gets escalated, you may find that you are escalated yourself. You may not think that you are showing it, but oftentimes you are, and your tone of voice and your language and your nonverbal positionings can further escalate a situation. So always be aware of yourself in a situation.
And just to add a couple of things to this, Catherine, we all deal with anxiety. This is a very normal human thing, right? And we all have different ways that we deal with it and cope with it. And some of us have what we call adaptive ways, fairly healthy ways to deal with our anxiety. But some of us have ways that are maladaptive. They're not beneficial to us. It's something that when you go into the healthcare setting, you no longer have access to. So let's say, for example, that part of your mechanism for coping in an anxiety-provoking situation is to smoke a cigarette, right? Well, you're in a hospital, you don't have that, right? Let's say you're used to having some other kind of substance that you use to help you cope. Well, you're in a specific situation like a hospital, for example, you do no longer have access to it. So it's really, these tools help you to kind of assess that piece of things as well. And also the thing I really want to point out here too is that this says de-escalation, but really a lot of this is, pre-escalation. You're trying to keep from escalating patients. And if we're really cautious and smart about how we engage with patients, sometimes we can avoid escalating them as well. And like Catherine says, when we get really busy at work, we're moving from patient to patient, or maybe you had a tough conversation with another patient or a family member, and then you walk into another patient's room. you may be still carrying some of that body language from that previous interaction. So it's really, that self-awareness is really crucial in helping to manage your patient's anxiety.
That's all very true. All right. This is another assessment tool that we are going to share with you all that's important to keep in mind when you are dealing with other people. So it's STAMP, and it's an acronym. So the S stands for staring and eye contact. You may find that when someone is starting to get agitated or escalated, they maintain eye contact too long with you, or they're staring at you. The T stands for tone and volume of voice. Someone could get very loud or very soft in their volume of voice. The A is for anxiety. Anxiety can manifest in many different ways. A person could be shaking, they could be tearful, their pupils could be dilated, or they also may appear just frozen. The M is for mumbling. You might not be able to understand the person as they're speaking. Their speech could become very, very rapid or slow, or like I said before, the volume could change. And then lastly is P for pacing, but this also could be any subtle changes in their body movements that may indicate rising signs of anxiety. All right, so now we're going to get into the Perryman care cycle, and yes, it is named after Paul Perryman. He came about with this care cycle as a way to teach and explain people how to provide care to individuals, all while maintaining their own safety and the safety of the patient. He came up with this in 2023 from his own experience. Before his current role, he was a nurse leader in the psychiatry service line, and then also with support of the literature, created this care cycle. So with every interaction, we want to use the de-escalation tools we have already mentioned, and assessment tools for anxiety and agitation, such as STAMP. But it's important to enter in interactions, especially with patients, with establishing a daily routine. Like we've talked about before, patients and visitors have lost a sense of control when they are in an unfamiliar healthcare environment with their medical stressors that are going on. So giving them a sense of power or control and knowing what to expect by allowing them to make decisions, planning their day, how care is going to be delivered, lets them know what to expect and can ease their anxiety. Moments of caring are very important. These are small moments of connection where you as a caregiver or can speak with a patient or a family member of a patient about something personal to them that doesn't involve the reason why they are hospitalized. It shows them that you care about them as a person. It doesn't take too long, a minute or two, but it's a technique that can really de-escalate somebody and let you relate to them on a more kind of human level than as rather than the dynamic of patient and caregiver. And lastly would be providing choices. And so this was our example with Mr. Smith, where we allowed him to choose what time that the blood pressure or blood sugar was taken. And so that gave him back a sense of control in his care plan. All right, so here is the visual of the care cycle. And I know it's a little busy and it might be hard to read, but I'll walk you through it. So we start over on the left-hand side with the navy blue boxes. So working our way down, you would use your de-escalation techniques of entering the room, not rushing. You want to announce your entrance and introduce yourself. You want to tell the person why you are there, and you want to ask if now is an okay time to perform whatever task that you are there to perform. A lot of those things we have already covered. And then we enter into the cycle part of the diagram here, where it gets a little bit more nuanced. So the first stop in the care cycle is that continuous assessing of early signs of anxiety and agitation in someone else. And you can use the techniques such as STAMP. So while you're assessing for signs of anxiety and escalation, you're wondering, are they present? You're noticing, are they present or are they not? So if they are not present, you would just continue on with your care, and you would end the care episode once you were successfully done with what you entered the room to do. But if a person does get escalated, you may inquire why that is happening. You would state, hey, Mr. Smith, I see that you're really upset about getting your blood sugar taken. Is there anything I can do to help with that? Or is there anything you'd like to tell me more about that? Just by expressing interest and asking the patient for their input may de-escalate them. It may also make the situation worse. If it does make the situation worse, and then the patient, say Mr. Smith, starts throwing his stuff on his bedside table at you and starts yelling at you, you're not going to push it. You're not going to continue de-escalation. I want to point out down at the bottom of the care cycle is exit the room. Many arrows point to exit the room. If at any point you have addressed it and it is no longer safe to be in the patient's presence, you're not obligated to be in there anymore, and you can exit the room. And it's important to note that once you exit the room, you do want to escalate those concerns. You want to document it. If you're the caregiver, you want to make the interdisciplinary team aware that this happened, that the patient is not only resisting their care plan, but also showing signs of, say, verbal or physical assault, whatever happened in the room that made you leave abruptly and feel unsafe. You want to create awareness around that so that the team can rally around you to provide support, and then also create a care plan going forward that's going to be safe for you and the patient. Anything else to note, Paul?
Yeah, I think probably what I would add is that at the top there, where we're talking about what are the signs of signs of escalation present. So two things. One is, just because they aren't present doesn't mean a patient isn't experiencing some level of anxiety. So that's why those steps below it you're still needing to narrate your care. You still need to have like what we call a therapeutic rapport. You still need to be very supportive of that person as you continue to provide the care. The other piece is, as you move through each part of your care that you're giving to a patient, maybe you're starting off like in an outpatient clinic just by asking them questions, right? Have you fallen? But then you progress to something else. Now you're going to take vital signs. You kind of want to continue to do this reassessment of escalation throughout that process, because you don't know what might start to trigger that anxiety in the patient. So this is kind of like a cycle within a cycle that's happening, where you need to really consistently be aware. And then the other thing is moving from that signs of escalation to inquiring and see if they can be addressed, right? That is a skill set. I mean, there is a simple just asking questions, but this is where I think organizations can really support their frontline teammates in giving them some basic skills. For example, you walk into the room, you see the patient is just like tapping their finger on the side of the bed. Maybe that doesn't seem like that big of a deal, but it could be an indicator. So just pausing for a minute or a second to say, hey, Mr. Smith, I noticed you're tapping your finger on the bed. Is everything okay? Is there anything bothering you? And it may not have anything to do with the care you're about to provide, but it might bring up an issue. Maybe they've been waiting for a physician or another clinician to come through the room to give them lab results, right? And they've been anxious about it, but nobody's come. And we've seen in some of the literature for oncology that can be something that can increase anxiety and cause workplace violence against our frontline teammates. So now you've identified a problem before you've continued to give care that's unrelated to the care, but really needs to be addressed and might even be a high priority. Or at that point, you can validate them and then tell them, this is my plan to follow up on that after we deliver this care. And also as you do exit the room and close the loop, it provides an opportunity to communicate with the interdisciplinary team.
All right, so now we will move into institutional structures to address workplace violence prevention and response. And I believe Paul's going to start us off with this section.
Yes. And so like in this section, we're really going to talk about some of the work we've done here at UNC hospitals. So when you see some of these platforms that we're using, this is specific to the medical center. So just keep that in mind as you see some of these tools and examples. So really for the workplace safety program, what we really did was we kind of zoomed out. We looked at recommendations from OSHA, from Joint Commission, and we kind of have these 5 categories for how we like to think about our program: communication, assessment, prevention, support, and education. And so using that framework has kind of led to the program as we see it today. It's kind of grown organically over time. Here's my attempt at a timeline. I'm just going to kind of hit some highlights in here as opposed to reading all of these bullet points. But really this all started around 2013 or so. There was an event outside the hospital where somebody had followed somebody out onto a sky bridge. And, there were no negative outcomes from it, but it really raised the point that that person had no way to mobilize resources to help themselves. So from that came what we call the behavioral response here at the medical center. Now that behavior response team has grown over time. We now have house supervisors on it. We have a psych nurse who will come if it's adult, child psych nurse if it's with child psychiatry. We've are able to bring in pastoral care if they're available. It's had a few iterations where we've tried to include some other groups that have had some challenges, but it's still been a very highly utilized resource. Its utilization from 2016 to 2021 really was growing by 20% a year. So as the workplace violence increased, we also saw people really tapping into this resource. They found it very valuable. Also, kind of in parallel with that, in 2017, we did our first patient safety culture survey where we added in questions around workplace violence. We'll talk about that a little bit more, but that really brought broad awareness that our frontline teammates' perception of the violence that they were facing, we were not aware of how significant that perception was. So as a result of that, we were able to get an executive sponsor, a vice president for operations joined our Workplace Safety Program Council, which really helped us have the ear of leaders at the organization, which was amazing. We changed the name of our group to Workplace Safety Program Council to kind of align with the Joint Commission standards. This also led to the EPIC Safety Alert, which we'll talk about briefly, which is kind of like a clear and present danger alert that was implemented at the system level for UNC Health. And we had our first Workplace Safety Program Council annual report that we started in 2022. And right now, our latest effort is Workplace Safety Champions, which is to create kind of greater ownership of managing workplace violence at the unit level. So I'm just going to give kind of give a few examples of ways we're communicating with our teammates and providing them resources. So you can see here early on, we were on the far right, we were trying to encourage reporting of workplace violence. So we had our leadership team take pictures and we posted these around the organization. We also created front-facing signage for our customers that really communicated that this is a healing environment. In order for it to be a healing environment, we need you to treat our teammates with respect. And if you can't do that, then you may not be able to visit your family. And then we have some with stronger language. We have some that's very educational to front-facing staff, so our customers, so they know what we're talking about when we talk about behaviors that we do not want to see and that are not beneficial to our frontline teammates. And this is an example of a tool that we created for our frontline teammates that kind of captures some of these de-escalation strategies. and how to identify escalating behaviors early on and how to respond, kind of all in one place for our frontline teammates. So we have a question here for you. What estimated percentage of workplace violence incidents do you think staff enter in our SAFE portal at UNC Medical Center? So obviously not everybody works at medical centers, so just take your best guess. And our SAFE portal that's our reporting system for workplace violence.
Really appreciate everyone jumping in and sharing these answers. And I did see a hand up from somebody. And just to remind you, at the very end, we'll pop up poll everywhere where there'll be a place for you to submit your questions to Paul and Catherine. So we'll be on the lookout for that at the end. Actually, right after this, right after we finish here with this question, that will be available. So go ahead and start sharing those questions with our guests, and we'll get to as many of those as we can right at the end.
All right, so looks like most people are going for 32%, and we'll give you the answer shortly. We're going to keep you in suspense.
All right, so we already shared that the national rate of workplace violence reporting is at about 12%. And so we do, unfortunately, the rate at the medical center is much lower than national averages. So the answer was A at 2%. And so how we got that number is from our patient safety culture survey in 2022. There was a question on it that asked our teammates, our frontline teammates, how often in the last 3 months did you experience an episode of workplace violence? I think it might have been per week. And so we took those numbers, and as you see on this pie graph right here, that quantified to about 14,000 events. And then when you compare that to the same time period of 3 months to our internal SAFE reporting, it equated to about 1.4 of the reported events on the survey were actually put into our official reporting platform. So that indicates that to us that a lot of work needs to be done around event reporting. So we have mentioned that SAFE is our platform, and this little guy is the icon that stands for workplace violence in the reporting platform. And so we have to overcome a lot of kind of stigma with reporting and some barriers that are out there. We know a lot of the barriers that are out there because of our Workplace Safety Champion program, where we're getting more of a direct line of communication with frontline teammates. They tell us, why would I report? It takes a lot of time. Leadership never does anything. It goes into the black hole. So we've put together education and other methods to try and really enhance and increase reporting, because we really want to quantify all events, because we can't deploy resources or leadership support unless we accurately capture what is going on. So what a SAFE report does, it does help us monitor the trends. These trends can be looked at by unit. They can be patient specific. We know that one patient can maybe be involved in about 30 events. We've had that happen. And so then we can really do targeted interventions on just one patient. Could be a patient population, say there's a post-op population that is always waking up from anesthesia, very physically aggressive. An action plan could be perhaps the nursing team working with anesthesia to tweak the medical management of that patient so that it would lessen the risk there for the staff. And it could also be a staff population. Our SAFE reports capture 9 different types of workplace violence. It can be in the categories of staff to staff, patient to staff, visitor to staff, in the categories of verbal, sexual, or physical assault. And we also allow for people to mark if there was any discriminatory language that was included in the event, so that we can capture that as well. And a report is something, it's a good piece of documentation that we can reference later, and it allows upper leadership to gain insight into what is actually happening on the ground level. So what it doesn't do is it doesn't automatically activate a police response or any of the resources that we have, although we are working to link the reporting to supportive departments like HR, occupational health, Beacon, who covers our domestic and sexual violence, so that those groups can proactively follow up with employees after they report. We think that will be a very supportive measure and will encourage reporting if people actually receive that direct support after an event and if they report it. It's not going to automatically punish the offender or the person that entered in the report. And it's not going to directly prevent the future behavior, but we have been working on really standardizing data reports to be sent out to local leaders so that they, in conjunction with, say, their workplace champion or other local leaders, can monitor the data and the trends and be more proactive after looking at the data. All right, Paul has already mentioned this. This is our system-wide safety alert system. This is a way of providing instructions on how to safely care for an individual and to communicate a risk that that surrounds an individual in their different episodes of care at any location within our UNC health system. It's a label that goes on, or a flag that goes on the chart, and when you hover over it, it will include the care plan for the patient to keep everyone safe. We only put it on, there's a committee that looks at this and discusses whether or not it's appropriate. We don't want to stigmatize any patient. We want to make sure that the risk is really significant. It needs to be a threat with a weapon or a physical assault that caused harm in order for an alert to go on. And these alerts are reviewed on a regular basis and taken off when no longer appropriate. This is another tool we have in an effort to enhance our leadership follow-up after an event and standardize the language that is used by leaders, so we have a unified response. Laudio is a HR tool that we have for staff engagement, and it helps with turnover risk. So leaders can communicate with frontline teammates through this tool. And so this is a template that the council created because we know that we want to really increase that leadership follow-up. And it's not always easy for leaders that don't have that maybe personal relationship with that frontline team member, or if it was a really difficult situation of workplace violence, that they don't always have the language or the comfort level to provide that support. So this tool standardizes the language. It's able to be customized and personalized for the individual situation. And so you can edit it and send it through email. And then since it's through this program, it will track events on various employees. So you can tell when an employee is starting to have multiple occurrences of workplace violence. I think that was it for that. Okay, so employee resources. So we have a variety of employee resources and guidelines around the management of disruptive patients. I won't go through all of them, but we do have a SharePoint site where all of this information lives, and it's a place for leadership and frontline teammates to go and reference it when they need it. This is a sample slide of how we instruct our nurse managers to kind of embrace their role and responsibility in workplace safety. It's our way of, the council really encourages oversight of workplace safety and that safety culture to be promoted by local leadership. And so for you all, you might be in a variety of different healthcare settings. It might not be a nurse manager, but whoever it is, this role is someone who is going to be responsible for escalating events after they happen, closing the loop with staff afterwards about action plans that have been taken. They're the person that's going to connect with other teammates and follow up to offer support and resources. They're the point person that knows the other disciplines, the team so that they can bring an interdisciplinary team together to create a behavioral care plan, perhaps to make sure that these behaviors do not continue, and to enforce consequences if they do continue. And they're responsible for the ongoing education of the frontline teammates around various workplace violence resources. All right, and this slide is very busy, but it does, we do think it is a great visual that depicts all the nuances that are involved in the escalation pathways of workplace violence. It was created by Dr. Rebecca Bottom, who's a psychiatrist here at UNC. She's also my co-chair for the council. And it starts off by highlighting the two different types of workplace violence to give you a starting point of how to think about escalating and handling the follow-up of violence. So in the green circle, you'll see targeted violence. This would be more of the violence we have been talking about over the last few years, especially that was escalated with the pandemic. This is the type of violence where the person has malicious intent. Symptomatic violence is something that you're going to think of more traditional in healthcare settings of violence that is related to their illness or comorbidity, reason why they are hospitalized. They have two different responses. Targeted violence is going to have an operational response. Symptomatic violence is going to have a clinical response. They involve the same members of the team, nursing leadership, provider leadership, other various interdisciplinary care team members. But the difference is that symptomatic violence is going to be handled in a clinical manner. You're going to take into account their diagnosis, and perhaps there'll be some medical management there to ensure that the behavior is actually stemming from their diagnosis and following suit with that along that pathway. Then the overlap between the two is really around the utilizing consults. So there's a variety of different consults. You can individualize it for what you need in that situation, which is why it's in this form of a visual and not a really streamlined algorithm. It needs to be a tailored approach. So that can involve risk management. It can involve psychiatry or ethics. And then almost all situations are going to be in partnership with hospital police. So hospital police is right there in the center of the graphic. And then down at the bottom, we have workplace safety program, because we function more as an oversight council. We hold the resources, and we will partner with people and offer support and guidance if needed. And we create the different tools to help people, but we're not going to come in and solve the problem for people. We'll work in conjunction with the local leaders on these situations. All right, so Paul also mentioned that FY24, a big achievement for us was meeting the organizational goal of training a workplace safety champion for every inpatient unit. I believe it was somewhere around 50 units. We ended up training over 100 people over the course of the fiscal year. This champion went through a 4-hour training class, and they are expected to be a local resource on the units that can work in conjunction with their manager and leadership team to help engage staff. And they meet quarterly and have a direct line back up to the council. So we are receiving a lot of feedback from this group from frontline teammates around current state of workplace violence, which is very informative to the council in our work. And lastly, we have a recognition program, which is great for the champions. It's a way for leaders and champions, all teammates, to recognize someone who is going above and beyond to really use our resources, be a great advocate, and they're really dedicated to this safety culture. So we recognize them once a month on our Tier 3 safety huddle, which includes all executive leadership. So it's just a great way to really celebrate the positives that come out of these difficult situations. All right, and that concludes it. I think we're moving on to questions.
All right. Well, Paul and Catherine, thank you both so much. This is a question I was going to ask, so I'm so glad that one of our audience members shared something similar. Did you explore the reason for the low reporting rate? Could it be 1, busy workload, 2, not aggressive, violent enough, 3, lack of knowledge of the reporting channel? That 12% seems awfully low. Help us understand that.
Yes.
I think all, maybe we didn't directly answer this question during the presentation, but I think we touched on a lot of this in various ways. This really went into the development of the Champion program. When we had those results in 2022, it was decided, hey, one strategy could be really targeting the frontline staff. How do we capture their voice? And so we have done targeted interventions because we have heard directly from the champions that all of those reasons listed there are barriers. So there's been a lot of education and trying to make reporting easier and stressing the importance of reporting, and then actually encouraging leaders to follow up, because what we hear the most time is, why would I report? Nothing ever happens. So we want to close the loop with reports that go in.
Yeah. Well, thank you. All right. I have a new teammate who was recently spat in the face by a patient. The unit was aware of the patient's behavior, but did not inform the teammate. And there was no signage or documentation in the patient's chart. Had it been, I believe the teammate could have protected themselves. The question is there a way to ensure that the patient's chart includes a note about the behavior? And should this be prominently displayed so that all staff members who assess the record are aware? And I think, did that SAFE program, did that help to address that?
So, you want me to answer this? Or we have, so we've kind of like at UNC Health, we've streamlined our FYI flags. So this would fall under what we call a behavior concern. So we do have a way to put an FYI flag in Epic now, in which you can put like a care plan. And I think with that, you can put, you're always on that fine line of protecting a patient's privacy, not stigmatizing a patient. Their behaviors change over time. We've had spitting patients who at the beginning they're spitting and 4 days later they're not. So we have, you can, within those FYI flag, the behavior concern flag, you can put how to manage that patient, and then you can put a sign on the door that says, see FYI flag, behavior concern before entering a room. Those types of things I think are good strategies. They're not perfect, but they are good strategies that also are sensitive to the patient.
Yeah, I think when people say this to me, I do a lot of, and Paul has done this as well, lots of education to our teammates and our leaders, really try and stress that importance of everyone's responsibility in the safety culture, which is a unified front. So everybody has to play their part. So everybody has to play their part in communicating the risk. And then also that slide I had about the nurse manager role, we stress to local leaders such as nurse managers that they are perhaps the one person that is going to be owning that communication process if the staff aren't initiating it.
All right, thank you. And of course, the audience for this presentation is not just here at the Cancer Hospital or here in Chapel Hill, but people from other UNC affiliates and beyond, and other organizations within North Carolina. So the last few slides about workplace violence, are those programs available to all UNC Health facilities? I'm interested in becoming a WPV champion.
Currently, we just have it for the medical center. We recently spread it to Rex. We had a lot of Rex teammates or leaders come and take the class so that they could take the materials back. More than happy to share materials. And we have shared it at some of the system leadership levels, but currently it doesn't exist outside of the med center, but we are happy to collaborate with people to share how we structured the class and some of the materials that go into it.
And I think that's like kind of one of our hopes for like why we like to come talk to people is to share ideas, to hopefully give other people ideas to go to their organizations or entities to try to implement things. And then, of course, happy to be a resource as we can for starting those things.
Great. Well, Catherine, Paul, thank you both so much. We have more questions, but unfortunately not more time. I want to say quickly thank you to the people of North Carolina for the funding of the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, the team, Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Barbara Walsh.